Welcome to the AUA Inside Tract Podcast. Today's podcast is part of the Meet the Subspecialties series and is brought to you by the Residents and Fellows Committee. Dr. Jose Ivan Robles-Torres, PGY5 Urology resident at the Hospital Universitario in Monterrey, Mexico, sits down with Dr. Sammy Elsamra, Associate Professor of Urology at Rutgers Robert Wood Johnson Medical School, to explore the subspecialty of endourology.
Hi everyone, and welcome to this episode of the AUA Inside Tract Podcast, Meet the Subspecialties. In this occasion, we will talk about endourology. My name is Jose Ivan Robles-Torres, PGY of 5th year at Hospital Universitario in Monterrey, Mexico, and I'm currently Mexico representative at the AUA Residents and Fellow Committee. Our talk today will be more focused on robotic surgery, which is one of the many fields covered by endourology. And before we begin, it is my great pleasure to introduce Dr. Sammy Elsamra. Dr. Elsamra is currently an associate professor of Rutgers University and former chair of the Young Urologist Committee. He has an impressive research career with an extensive list of publications, and he did his endourology fellowship at the Smith Institute of Urology. His areas of interest are robotic urology in oncology and reconstruction. Hi and welcome, Dr. Elsamra, and thank you so much for your time. Would you like to talk a little bit of yourself and your background before we get started?
Sure. So I'm Sammy Elsamra. I'm an associate professor of urology at Rutgers Robert Wood Johnson Medical School. I'm a New Jersey native, and I was always interested in going into medicine, but I also really enjoyed technology and innovation. I actually did an engineering undergraduate education. I switched over to chemical biology, and then I went to medical school at New Jersey Medical School, so not too far away from home. I've completed my residency in 2012 and then my fellowship in 2014. And, I got the opportunity to take a job at Rutgers Robert Wood Johnson since 2014. I had a long experience here, and then I had a short opportunity to go back to Brown, but Corona, I think, made things not ideal for my family situation. It was a perfect situation for me, but it was not ideal for family situation. So I found my way back to Rutgers Robert Wood Johnson, and that's where I am now. And I'm, fortunately, doing a lot of my practice is mostly robotics, with a little bit of endourology.
Wow, quite impressive, Professor. Something similar happened to me at high school. I was planning to study for engineer, and at my last year, I switched to medicine. It was great for me. And indeed, I think you couldn't say it better. Urology is one specialty that constantly develop new technology and innovation.
Innovation is really key, and you can see that urology, unlike a lot of other specialties, not only do we just take out organs, right, but a lot of times we do a lot of reconstruction, and I think the robotic platforms really lend themselves to that very well. And I think it's I think there's a whole cadre of folks who, are innovators in the field, and it's inspiring to be around them. And, they are my, inspiration for when I go into difficult cases. I can reach out to them. There's a whole community of folks who are really passionate about robotic surgery.
Great. Dr. Elsamra, what led you to pursue a career in robotic urology? When does this interest started?
What really caught my eye about urology, I was contemplating a lot of different fields. What really got my attention was how we can treat so many things in a minimally invasive fashion. Some of the most interesting cases I found when I was a medical student were, a up and down scope for urethral realignment after a trauma. I remember doing stone basketing of multiple stones in a bladder. I found that to be amazing. I still vividly remember those cases, and I still vividly remember laparoscopic nephrectomies and partial nephrectomies and robotic prostatectomies at that time during my rotation and my away rotation. So I think that's what really drew me into urology. When I was a resident at Brown University, I was fortunate enough to, to attend a program that had a robust robotics program. I got to work on the Da Vinci S and then the SI system. And then, my interest in robotics was, from my PGY 2 year, I would try to sneak into the robot room, even as a PGY 2, and any kind of opportunity that I could get to sit on the console and to help out bedside, I would easily take up. I remember even asking one of my attendings if I could continue to throw just a couple extra sutures after they do the vesicourethral anastomosis. Something as menial as that was so meaningful to me when I was a junior resident. So I had excellent mentorship in endourology, and so I decided to do a 2-year endourology fellowship at the Smith Institute for Urology. In fact, when I interviewed, actually, my interest was always in laparoscopy and robotics. But when I was interviewing with Lou Cavusi, he said, "Why wouldn't you want to spend a year with Arthur Smith?" And I said during the interview, "My gosh, I get to spend a year with Arthur Smith. Okay, let me do an extra year." So I did 1 year with Arthur Smith and Zepho Kiki, and I learned a lot about endourology, stones and BPH. And then the next year I spent with Lee Richstone and Lou Cavusi, four mentors really that I owe an enormous debt of gratitude for teaching me and showing me the way, and not just urology, not just the science of it, not just the technique of it, but the attitudes with which they faced difficult scenarios, difficult cases, how they dealt with complex patients. I learned a lot, and I learned some about life.
Dr. Elsamra, what does the process of applying to Endourology fellowship look like? Is it hard to get accepted? Is there a lot of competition? And what recommendations can you give to urologists who are about to apply?
Well, I'm a little bit far removed, so I don't probably have the most up-to-date information for applying for the fellowship. But that being said, the Endourology Society does have 1 year and 2 year fellowships. There are 1 year fellowships that are robotic focused. There are 1 year fellowships that are stone and BPH focused. There are 2 year fellowships that are both years are clinical, and there are 2 year fellowships where it's 1 year of research and 1 year of that clinical entity that you decide. I also know that there are several robotic urologic fellowships out there that are not part of the Endourology Society. And I think there are several robotic urologic oncology fellowships that are also, they may be part of SUO, I'm not quite sure, but they're out there. I think, application is typically during your PGY 4 year. So I know we have a couple of PGY 4s right now who are applying for robotic MIS fellowships. And, the application starts really around this time. So in December of your PGY 4 year. I don't know if the fellowships themselves are difficult. I think, market forces are such that you probably, could go out and get a job, and a lot of folks want to do that. And so maybe it's not super competitive. I'm sure certain fellowships are going to be competitive, but, I think it varies from year to year.
Great. You just mentioned an important point. What is your perspective regarding robotics training in an endourology fellowship compared to an oncology urology fellowship? Is there any difference, or the procedures are quite similar, the training is similar. What
Yeah.
is your point of view about it?
Yeah, certainly there's some overlap between urologic oncology and endourology when it comes to robotics. I think the focus is very different, and urologic oncology has this strong um, history of academic rigor. A lot of the treatment pathways are regimented. And I think that's really, obviously there's a big component of open surgery if you're going to do a urologic oncology fellowship. Um, and I think that's the strength or the reason to do urologic oncology fellowship. A robotics fellowship, particularly one through the Endourology Society, will have exposure to oncology. And to my understanding, there are efforts underway to kind of shore up or standardize the minimally invasive urologic oncology curriculum that is throughout that. But I think, it's different. It's a slightly different focus. Robotic fellowships through the Endourology Society are more likely to treat not only urologic oncology, but upper tract reconstruction, some simple prostatectomies, bladder diverticulectomy, those types of cases, which probably you would not get to do in urologic oncology. I also think that the focus is a little bit more towards innovation and technique, right? And so the SP, for instance, is a relatively new addition to the robotics armamentarium. And I would argue that it's probably more likely that you will get access to an SP, single port robotic system, and have a, more volume or more experience on the single port in a endourology focused MIS or robotics fellowship, as opposed to urologic oncology. So I think that that's going to be the slight difference.
I agree with you. I think that endourology fellowship, specifically in robotics, have a more extensive field of diseases to treat, and that's a big strength of endourology, in my opinion. What recommendations can you give for early exposure and introduction to the field of robotics?
I think robotics is ubiquitous. When I was applying for residency, it was not necessarily so. I remember interviewing back in the mid 2000s, and a lot of programs were saying, well, we don't know if the robot's here to stay or not, this kind of thing. I think a lot of people did prostates begrudgingly. They're like, why would we take 4 or 5 or 6 or 7 hours or whatever, however long it was, to do a robotic prostatectomy with the time of setup and the cost and all that, when we could do an open prostatectomy, for instance, in an hour and a half or whatever the time may be. And I think you fast forward 15 years or so, and you see that, my gosh, 95% of radical prostatectomies are done robotically. So there is really some real benefit there. I know there's all sorts of criticism with regards to the company that makes robotics or the robotic platform, but there is something there. It's undeniable. It is here to stay. That's true for the multi-port, and a lot of people will argue that the same story, is being played out with the single port right now. That there are a lot of naysayers for the utility of the single port, or its applicability, or its diffusability, and we've seen that before, and the argument is, and the fear is, or the concern is that, hey, SP1 may not be that platform that's going to work for everybody, but maybe SP2 will be. And so if you get your experience in on SP1, you're that much more proficient when SP2 comes out. I think if you have an interest in robotic surgery, you, you know, I think deep down inside, you know, your passion is going to be what's going to drive you and what's going to make this marathon of your training and then your career easy. You know, for me, you know, when I was PGY2, I would slip out of the floor and go into the robotic room, whatever I could. You know, I would just check things out. I'd be checking things on the computer in the room, looking at the video, you know, the video feed. I would, again, like I said, as menial as it was, just tying those extra knots as a PGY2 or 3, I think that, you know, gave me some extra licks. We didn't have robust simulators back then, but when the simulator did come out, I remember Ring Rail 3. Man, I would try my best to get that thing to like 100% and under a minute, and I would move all the rings around the rail like in no time. And so it's something I really enjoyed doing.
Unfortunately, here in Mexico, we live a very different situation. For example, radical prostatectomies, more or less 45 or 40% of them are performed with open technique. More or less 50% is performed laparoscopy, and only like 5 or less percent is performed with robotic technique. So it's a big difference compared to the US, for example.
There's no doubt that we're in a privileged situation here in the US where we have that technology and it's ubiquitous. You know, the opportunity cost is already spent, right? So the robots are already there, so we use them. But you know, if for folks who are listening from, you know, outside of the US, you know, get involved in laparoscopy. You know, the fellowship I did, there was still a lot of laparoscopy. We did laparoscopic partial nephrectomies. And I'll tell you what, seeing, you know, Lou Cavusi and Lee Richstone do what they did laparoscopically, that really prepared me to, you know, become an even better robotic surgeon. So, you know, the efficiency with which you were able to do things in an unwristed instrument just allowed me to propel even more when I gained that wristed instrument. So my advice to you and to any of our colleagues outside of the US, if you don't have access to a robot, sure, you can watch the videos and all that, but use what you have in a minimally invasive fashion. Get really good at laparoscopy, you know, and if the opportunity comes where a robot, you know, comes into your system or you go into a system that has a robot, you'll be that much more prepared.
Great. In your personal point of view, what do you think is more complicated to learn between robotics and laparoscopy?
I think that robotics is probably easier to learn. I think robotics has better ergonomics, obviously. You know, you probably know this more than most, right? Try to do a lap prostatectomy. That is not an easy procedure on your back, you know?
Not at all.
So, you know, operating from the side tilted is probably not ideal. So just being able to sit down is better. I know laparoscopy has all these adjuncts with 3D visualization, with glasses and this kind of stuff, but you know, the visualization, the optics on the robot is just superb. The stereoscopic vision is amazing. You know, the speed with which, you know, the scaling of your hand motion to the robot motion, it's modifiable, by the way, right? I always put mine on the quickest setting because that's just what I'm used to, but it's really nice not having to hold the camera or have someone hold the camera. You don't have to rely on someone to hold the camera. That makes it easier. You know, not having to require an assistant to be super steady. Like if you're going to staple bowel, and you're trying to have them hold steady while you're putting the bowel on the stapler. I don't know if you've ever done that with an assistant, particularly someone who's new or not in a favorable position. Right there, the stapler's moving, you're holding the bowel. That's not an easy thing to do. Or robotically, when you put the robo stapler in and you clutch off of it, that stapler is not moving. right? And so you can put your bell on there. So there's so many things that make it ergonomically much more easy. But, having said that, I think there still is a benefit. I think a lot of my quick adoption of robotics and a lot of, my, efficiency in robotics came from understanding laparoscopy very well. So I still think that there is a benefit to knowing laparoscopy.
You couldn't say it better, Dr. Elsamra, and I agree with you. So do you think that training programs should be in a stage fashion, like by steps? First, you dominate open surgery, then you do lab, and after that, robotics. What is your perspective or your point of view about it?
My answer is yes to all those. Wherever possible. I think every institution has a different skill set and a different capability and a different philosophy, but as a resident, you should consume it all. You should be hungry for every case. Anatomy is the same, whether you do open, lap, or robotic. And so you should go in there and do it open and be the best that you can at doing open surgery, and then try to understand that anatomy and understand how did you retract the ureter, how did you dissect the bowel, or how did you dissect the pedicles open, and then see what the differences are laparoscopic, and then see what the differences are robotically. I think laparoscopy it's hard because it's hard for folks to do laparoscopy because robotics, has taken over. I think just the way systems are set up, it's probably just easier for a lot of folks to do robotic surgery as opposed to laparoscopic surgery if you have a robot present. And mind you, when you go into your career, you're going to be good at the things that you do often. And we cannot all be great at everything. That saying, it's a little cliche to say this, but there's jack of all trades, master of none, So I think if you are going to pursue a career where your focus is robotic urologic surgery, then I will tell you there's no questioning this. It is to your benefit to try to do robotics at least once a week, if not more than that. So I think you're not going to really get to that level of proficiency. And mind you, you don't stop learning when you finish fellowship. There's a lot of growth that happens beyond fellowship. I've learned a lot, in the past, 8-9 years of my practice. The proficiency and the skill that I have on the robot now is very different than when I started out and, as an attending. So you continue to learn, but you only continue to learn if you continue to push yourself. So I think whatever you do it often, right? And I think that's the way to become most proficient at it. But when you're a resident, do it all. Absorb it all and then decide. You got to absorb it. Open, lap, robo, percutaneous, endoscopic, whatever it is, do it all, and then you decide to focus after that.
I understand that you need to say yes to everything. Yes, sure. Some of my professors say the same thing. You need to dominate open surgery, then you need to dominate laparoscopy, learn laparoscopy, and then robotics. It is more easier to learn compared to laparoscopy when you first dominate laparoscopy.
Well, and I think, to put it in a sequential fashion is not the best way. I think, all of them all at once as a resident, do it all. And I'll tell you, I, from time to time, I have to do an open case, if I have like a complex case with another service and they have to do it open, I'll be there and I'll do the open case. And I had a case where we had to do a ileal conduit open and a patient who needed a big open incision and some other case. And we were, dissecting out ureters that were chiseled in the retroperitoneum. But my familiarity with the anatomy and my techniques from robotic, I feel made me an even better open surgeon, right? So you do learn open surgery as well from robotics, not just robotics from open surgery. I think the knowledge flow or the experience flow is in both directions.
I agree. We need to get prepared to those complex cases and to be prepared for that cases that that there's a high risk that will convert to open surgery. Well, Dr. Elsamra, what do you consider are the most important strengths or advantages of your field, specifically in robotics? What do you consider are some handicaps also?
So the strength of robotic surgery is that more and more procedures are being done robotically, right? So if you look 10 years ago, it was probably only prostatectomy, and maybe folks were dabbling into some partials, right? Before the XI, the partials were not great. Definitely retroperitoneal partials were not great at all because it was very difficult to fit the SI in the retroperitoneum. So I think with the newer technology, with the XI and somewhat with the SP, we're able to do, lots of procedures in a fashion that is, I would say, adhering to oncologic principles that you would, do in an open surgery in the same way, or adhering to reconstructive principles as you would with any other approach. And so I think that there is definitely more procedures being done robotically. I think that there is a sense of marketability, right? If you say that you do robotics, I think there is a marketability there. But the downside is a lot of folks say that they do robotics, right? So, fellowship trained or otherwise, there are folks who say they do robotics, and, it's hard to differentiate yourself. I think it's probably not as strong of a differentiator as it used to be. I think also that, we mentioned that there is overlap, right, with other specialties. So that, if you're a robotics guy, the criticism is going to be that this is a technique-based fellowship or a technique-based approach and not necessarily a discipline-based approach, right? Recon person will say, well, you're not a true recon person. You didn't do a recon fellowship, right? You're just applying the robot to recon, right? The urologic oncologist can say the same thing, right? But at the end of the day, if you adhere to the principles, obviously, you have to continue to read up and be knowledgeable and have good, mastery of the discipline, right? Then applying that robotic approach kind of gives you a little bit broader, treatments that you can offer, broader diseases that you can treat, I should say.
Yeah, definitely. As you mentioned before, your improvement of your technique doesn't end with your fellowship. You need to continue doing surgeries, constant surgeries to increase your cases in order to be an expert, for example.
I'd like to piggyback off of that last statement. I think it's very important. If you want to go out into practice and identify yourself as a robotic surgeon, well, then you need to be really proficient at almost everything that you could do robotically, right? The folks who only do a robotic prostatectomy or a robotic partial nephrectomy, there may be a role for them in big centers and what have you, right? But you should always push to advance yourself, right? You should always push to, hey, I used to do prostatectomy this way. Right now, well, we could do it. Can we do it Retzius sparing? Yes, okay, we do Retzius sparing. Or can we do single port extraperitoneal? Okay, yes, we do it this way. Or can we do retroperitoneal, partial nephrectomy as opposed to just transperitoneal, right? Continue to grow. Even if you didn't get those skills, and a lot of these skills we didn't necessarily get in our fellowship, right? Continue to grow in your practice, and that will lead you to be able to apply this beautiful technology to diseaes. Many times where there's a renal mass that's in the back of the kidney, very hard to do transperitoneal. Retroperitoneal makes it much easier, but you have to push yourself, always work. They say that you will continue to grow so long as you reach just beyond your capability, right? So I think that's a philosophy that I have, and I think that's a philosophy that is worthwhile for anyone who's trying to do robotics.
Great, Dr. Elsamra. Changing a little bit this subject, how is the quality of life of a robotic urologist compared to other subspecialties? Speaking of workload, stress, and daily rhythm, what do you think about this?
It's dependent on many factors. One of them being the practice that you're in. Are you part of a big department and they have said, look, you're just doing prostates and you have a setup where you could do 2 prostates a day and be done by 4 p.m. and everything's low stress, and then that can be a job trajectory that you have. It could be that you're a robotics guy and they say, hey, you're the cystectomy guy. Do all the cystectomies robotically. Your life is going to be very different. Cystectomies are urgent cases, longer cases, sicker patients. They all have issues. So I think that's going to affect your quality of life. And I think there's everything in between. If you join a group where there's 4 or 5 other people who are all doing robotics, and then you may not be so busy where it's stressful. Whereas if you're in a group where you're like, the one guy or something, then it's going to be very different. So I think it really depends on your practice. I also think a lot of it depends on what barriers you set for yourself, or what you decide for your practice. So the downside to my passion of robotics, and I love robotic surgery. I mean, this is really what I'm very passionate about, and I love going in there, and I'll go in there all the time. But the problem is then I'll go in there all the time and I'll set up cases all the time and I'll operate late, and that can affect the work-life balance. So I kind of have to remind myself to kind of pull back on that sometimes and to control my schedule.
Definitely. And it is a big issue when you have family, for example, when you have kids and everything. And this next question is like a personal doubt I have. And I think a lot of urologists are in the same situation. We are both parents. And I'm a urologist who's going to apply for fellowship as a parent. So what recommendations can you give for those urologists like myself that have family, that have kids? What recommendations can you give us?
I think, and I'm not the best example at this, so this is, advice for myself as well as for our listeners. I think it is very important to be present wherever you are. So if you're at home, you're not at work, all right, just shut it off, be present with your kids and with your family. Identify the time that you're going to be with them and make that time memorable and worthwhile, and savor it. Okay. When you're at work, be at work, don't be distracted wherever you are. So I think being mindful and thoughtful of what you're supposed to be doing at the time, I think that's key. I think also kind of, setting the expectations, pre-warning, hey, my wife's, her name's Nancy. Hey, Nancy, this is a rough fellowship, I'm going to be signing up. Are you okay with this? This is going to be a sacrifice for both of us, and also turning around and being like, Nancy, I couldn't do this without you. You're my rock. You're my everything. And if, in case Nancy's listening, that's for you, Nancy. But I think that's you have to, get buy-in from your family, and you have to warn them and tell them. And then I think also, this is kind of an extrapolation of what you're saying. I'm a big believer in community. I grew up in New Jersey, and I have a lot of ties in New Jersey. There are a lot of folks from my community that come and see me, and I treat them and all this. And sometimes there is something magical when your work is benefiting your community. I find so much satisfaction in that. When I treat someone who like knows of me, or their family friends, or their distant family, or what have you, right? And they come in, I think I'm being active in the community, but also being a urologist and working. And I think that's great. I haven't figured out a way to meld family and work fully just yet, but I'm sure they're there. And I think, knowing that you're going to work to earn a paycheck to support your family is part of that. And I think, reminding yourself of that is important, but I think that's part of that mindfulness that's not unique to robotic urologic surgery. I think that all urologists need to practice that.
Yeah, I think it is very, very important to get things balanced with your family at home, balance with your work at the hospital. You need to have stretch communication with your partner.
Yeah.
You need to have that extra support that you need, the confidence you need, because not every day it's a good day at the hospital. And for example, in my case, I feel sad, I feel disappointed with something. My wife is the person that cheered me up. All right, well, I guess that was our last question. Dr. Elsamra, do you want to add something else to this great conversation?
I just, again, thank you very much for the opportunity to discuss this. This is obviously, the time has flown by because it's so much fun talking about this. And I think at the end of the day, particularly for the residents and the fellows that are listening, really understand what your passion is and then search that out. I think that makes things so much easier for you. For me, it was easy and clear to understand that, in that I loved minimally invasive surgery. I really gravitated towards robotics early on. And don't tell my employer, I would almost do this for free, so I just really enjoy it. That shows, even if I'm having a rough day, even if it's a long day, even if there's a little bit, things aren't going as smoothly or as ideally as they should, and everybody's going to have those difficult days. I just remember I'm very blessed to do what I love to do. Not everybody has that chance. And so I think, it's really important to find what your passion is and let your passion drive you. And then you got to put in the hard work, right? Everybody sees, these big names, a lot of my mentors and supporters, they're big names in urology, and you look up to it like, wow, that's amazing. I'd love to do what they do. Right. But are you prepared to do what they did to get to that point? And so for you to be a master, whatever type of urologist you're going to be, right? Master urologic oncologist or FPMRS person or recon person or robotics person, whatever it is, right? Yes, everybody's attracted to the person who's standing, at the plenary, but are you willing to do the work that they did? And if you have that passion, it'll be easier. But if you don't have that passion, maybe look for it elsewhere.
Dr. Elsamra, once again, we appreciate your time and thank you for sharing with us all your advices and your experience. No doubt this would be very helpful for urologists who are planning to start their career in robotics, like myself. Thank you very much.
Jose, thank you very much. It was a pleasure, and I appreciate it. Thank you to the AUA, and thank you to our listeners. Thank you.
This has been an AUA Inside Tract podcast brought to you by the Residents and Fellows Committee. Check out the AUA University podcast for weekly episodes on the latest clinical updates and advances in urology. For more information about the AUA and membership, visit auanet.org.